Medurstand. Understanding medicine.
I am Professor Aziz-ur-Rehman, and today I am going to record a video on a very common problem but often overlooked. And the topic is diabetes and men's health, including erectile dysfunction. Because of the sensitive nature of this topic, it is often not discussed in our various symposia, so I thought it is very important to cover it in my video. And just incidentally, next month, June, is the month for men's health. So I think with that reference, you will find this video very relevant. Now, this is the agenda. I'm going to briefly talk about all these things like possible sexual abnormalities in diabetes, normal mechanism of erection, because unless you understand the normal mechanism of erection, you would not understand the abnormalities seen in diabetes and the mechanism of action of various drugs. Then evaluation, how we should take this case and how do we evaluate him, and based on history, physical examination and laboratory investigation, we should come up with a plan for that given patient. Then briefly, I will talk about the relevance of diabetes with erectile dysfunction, treatment of erectile dysfunction, and then finally the treatment of other sexual abnormalities which we see in diabetes. So it is going to be a little lengthy video because of the nature of that topic. Now, these are possible sexual abnormalities in diabetes. Loss of libido, that means one loses the interest in sex. Sex is considered to be one of the universal pleasures. So if one loses libido, if one loses interest in sex, that indicates some serious problem related to his physical health or sexual health or mental health. Then erectile dysfunction, previously it used to be called impotence, and this word is not used these days for two reasons. Number one, it is very derogatory, and number two, it usually implies complete loss of erectile function, whereas in real life there could be partial loss. So erectile dysfunction better describes this condition, and that is a word which we use these days in literature. Then hypogonadism, of course it's a separate condition and I have already covered that in my lectures, but hypogonadism can occur in association with diabetes also, and I'll show you that this is actually fairly common. Then premature and retrograde ejaculation. Premature means the truly premature ejaculation would mean that before penetration there is ejaculation, but if it occurs immediately after penetration, that would also be called premature ejaculation. And retrograde ejaculation means that the semen goes back into the urinary bladder, doesn't come out. So retrograde ejaculation and very premature ejaculation would also probably translate into infertility. Then anorgasmia, that means one doesn't get that orgasm. So that is again a problem. So I'm going to cover all of them briefly, but as I said earlier, the main emphasis would be on erectile dysfunction. Libido and the sexual performance, they are interdependent. Of course, one has to have libido, only then there will be arousal, only then there will be erection, and then one will be able to do the sexual activity. But depending upon the sexual performance, the further libido will be affected. For example, if one performs very well, that will perhaps increase his libido the next time. But if someone's performance is poor, then due to performance anxiety, his libido will be reduced. But libido usually means there is some problem with some psychological problem or some endocrine problem or some physical problem, mostly related with brain. So I think libido is, the loss of libido is very important and must be looked into. Then erectile dysfunction is very important because this is required for normal sexual function, and uh, it has got various bases. Why do one get this erectile dysfunction? In diabetes, there is possibility of autonomic neuropathy. We all know diabetes affects all types of nerves. Autonomic neuropathy is fairly common. You must have heard people complaining of bloating, indigestion, distension, gas in the abdomen, urinary difficulties. Similarly, this erectile dysfunction could be due to autonomic neuropathy. There are some specific clinical and laboratory tests to determine the presence of autonomic neuropathy, but often these are not done. So there is one good possibility that the given person with diabetes with erectile dysfunction has autonomic neuropathy. That person might have some other symptoms like postural hypotension and other stuff. We also know that diabetes affects our main vessels and the small vessels, and it accelerates atherosclerotic process because normal erection requires good supply of blood, which increases to 6-7 fold during erection. So I think unless you have good blood supply, you cannot have normal erection. So if there is atherosclerotic involvement of the feeding vessels, there could be that could result in erectile dysfunction. Then there may be atrophy of the trabecular smooth muscles. The corpus cavernosum is consists of trabeculae, and they have smooth muscles in their walls which remain in the state of contraction in flaccid state, and only during erection they relax and dilate. So if these muscles are atrophic, then again that could affect erectile function. Then medication, many anti-diabetic medication and many other medicines which these patients are taking for their neuropathy, for their associated condition. I will go through the list later. They could also be contributory to the erectile dysfunction. Then psychological factors, and of course, psychological factors are important. We believe that even if somebody has a physical cause of erectile dysfunction, there would be some psychological overlay. But in some cases, the cause of erectile dysfunction may be purely psychological, and we will see how we differentiate between physical and psychological causes of erectile dysfunction. Now we're done with this first component, the possible sexual abnormalities in diabetes, and now we're going to discuss the normal mechanism of erection. For normal erection, we need various organs and systems in their perfect state. We need a perfectly functioning brain, the nervous system, the peripheral nervous system, the somatic nervous system, parasympathetic nervous system, and sympathetic nervous system. We need to have normal vessels without any problem narrowing. We need to have a good background endocrine system, particularly pituitary and gonads, and then we have the testicles and the seminal glands. So these all are related to work on the sexual organs to perform normal erection. So I will very briefly go through these steps. The first of all, the first step is arousal, and that occurs in the brain. That means one is charged to have sex, and this is actually triggered by visual signals, olfactory signals, auditory signals, or tactile signals. So all these collectively, they stimulate that part of the brain, I think hippocampus, which actually arouse one to do the sex. So this is the first thing, and then it would actually lead to the stimulation of parasympathetic nervous system. Now, out of two components of autonomic nervous system, the parasympathetic nervous system is the first one which comes into action, and sympathetic nervous system will also be involved, but slightly later in the when there is ejaculation and there is orgasm. For initially there is parasympathetic nervous system and also somatic nervous system, the peripheral nerves and the blood vessels. And because these nerves, they are stimulated, parasympathetic nerves, they release nitrous oxide through the sacral nerves, the nerves supplying through the pudendal nerves, the penis. They release nitrous oxide, and nitrous oxide is a vasodilator and muscle relaxant, and then it causes increased blood supply to the penis by dilating cavernous arteries, and later on there will be a sympathetic nervous system. Now, nitrous oxide, once nitrous oxide has two functions. One, it is the neurotransmitter released from the nerve endings of parasympathetic fibers, and then it also activates cyclic GMP. Now, cyclic GMP is also something which dilates blood vessels and cavernous. So I think these two are extremely important. They do two things. One, they dilate arteries so that there is increased blood flow to the penis, to the cavernous. And number two, and they also relax smooth muscles in the trabecular wall, so increasing their capacitance. So more blood comes into the penis, and that leads to engorgement of the trabeculae. So because of the engorgement, the emissary veins, which I'm going to show you later in the slide, the emissary veins which drain blood from the cavernosa, they are compressed against tunica. So blood is sort of retained in the penis. That is what leads to erection. So we call it in technical words tumescence. That means the rigidity is achieved, and then then the sympathetic nervous system comes into play. Once we achieve orgasm, sympathetic nervous system comes into play, and that leads to contraction of the epididymis, contraction of vas deferens, and contraction of seminal vesicles, and then also the contraction of some pelvic smooth muscles, pelvic muscle, that leads to ejection of semen, and that completes the act. And then finally the sympathetic nervous system shuts off everything. The blood vessels, they come to their original state. The trabecular muscles also contract, and the emissary veins also start draining, and then the penis becomes flaccid, called detumescence. So this is the cycle. I hope you have understood this. We are going to repeat this again in the slide when we will discuss the erectile dysfunction. This was actually the normal mechanism of tumescence and detumescence. Now, we continue with normal mechanism of action. Now, this is revision of what we saw in the last slide. These are the blood vessels, cavernosal arteries. These are the arteries which supply blood to this cavernosal tissue, and the blood supply increases 6-7 folds during erection. These are the trabeculae, which are normally empty, but once smooth muscles relax, that increases their capacitance, and that increases the blood present in them. And once there is engorgement, it compresses these veins. So you see these emissary veins, these veins, they get compressed against this tunica, and they stop draining. So blood supply to this tissue is increased, and drainage is reduced for some minutes, and that leads to this erectile state. This is tumescence. You see these trabeculae now are filled with blood, and they are engorged, and these veins are compressed. So this is the erectile state. If due to any problem because of the poor supply to the arteries, poor autonomic nervous system which dilates these trabeculae, or when there is problem with the venous drainage, there is leakage of the veins, there is tear in the tunica, all these will interfere with tumescence and will cause erectile dysfunction. Sorry, this is actually some region. How does this happen? When there is parasympathetic stimulation, the nerve endings they release nitrous oxide, also prostaglandin E1. Both of them are vasodilator. And the second step is this nitrous oxide converts a primitive form into cyclic GMP, and which is vasodilator, and also which is smooth muscle relaxant, which relaxes these muscles, and they also produce intracellular calcium, which is also has a vasodilator action. And then we have that increased blood flow and relaxation of smooth muscles, and venous flow is reduced. So all these things they lead to engorgement. There's a little bit of repetition, please bear with me, but that is how we understand the concept well. Now then the fourth point is then sympathetic nervous system comes into play and endothelin is produced, and then something called this ROK, this is also produced, which is vasoconstricted. So that terminates and complete the sexual activity. That is usually followed by a refractory state, because after one sexual activity, usually for several minutes, because of the activated sympathetic nervous system, another sexual activity is usually not possible. Now, I hope I was able to explain the normal mechanism of erection, the system involved in that, and now I'm going to evaluation. Evaluation, very important, the clinical part. Uh, we have already mentioned that this is a very common problem and very unfortunately not duly recognized. Many times patients are reluctant to discuss this issue, and we often also do not encourage patients to talk about their personal issue. And another issue is that patient come for their general consultation for their diabetes control, and maybe at the end they might mention that they have this problem also, and we may not have enough time. So ideally, I think if somebody has this problem, he should go to the doctor exclusively to discuss this erectile problem, and so that the whole consultation time is given to this. And I suggest if patient mentions at the end that he has this problem, I think patient should be asked to come again, because it would require a lot of time. So patient should be given due time to discuss this issue, should be encouraged, because naturally patient would be very reluctant to discuss this issue. So let's see how we do that. Now, in evaluation, first of all, we need to take a detailed history. Now, history is a great tool at our disposal. It doesn't cost anything, and careful listening to patient's problem resolves half of the problem. So history must be taken, and the literature says that both partners should be present when you take history. Now, but in our literature, in our culture, it is often not possible, because women are particularly reluctant to discuss these issues. And I recall in my practice, at the end of consultation, patient comes for their diabetes consultation, and at the end of the consultation, they would request the wife to go out. And immediately I guess what they're going to discuss this issue. Immediately I guess that. Now, in a very, very brief time, we have to discuss. I think in our culture, we may still continue to practice this, that this problem will be discussed with man alone, if that is the patient's preference. But significant time must be given, because you need to know some personal details. I think that should be one sitting exclusively dedicated to the history of erectile dysfunction. We would also like to know his actual problem. Now, sexual history, is the problem is lack of libido, or poor erection, or premature ejaculation, or whatever the problem related to the partners. So I think the detailed sexual history should be taken, and if it is uh, related to specific partner, so I think that is important. Now, medical history, all these patients with diabetes, they are taking multiple drugs, the anti-diabetic drugs, and many other drugs which are prescribed for associated comorbidities. So I think we need to know exactly what medication patient is taking. It may be just one of those medicines which is causing erectile dysfunction. Patient might not need any investigation. All you have to do is to remove that drug. Then psychosocial history. Of course, patient's psychological background and patient's social background need to be considered before we come up with a plan. Sometimes some social issues and some psychological issues are responsible or at least contributing to erectile dysfunction. In physical examination, cardiovascular system should be examined, patient's blood pressure should be checked, patient's heart should be examined, and patient's peripheral pulses, particularly in the lower limbs, the dorsalis pedis and posterior tibial artery, and they must be checked so that we know that the peripheral vessels are okay. Then we need to examine patient's central nervous system and peripheral nervous system. The sensations in the lower limbs should be checked. The position sense and reflexes should be checked. If they're absent, that would indicate the presence of neuropathy. So that could be actually contributory to the erectile dysfunction. Now, in ideal situation, you should also do the test for autonomic neuropathy. For example, the pressure changes when the postural drop in blood pressure, the changes in the pulse rate and changing posture, Valsalva maneuver. So there are various tests for autonomic nervous system, and if available, they should be done. Then examination of genitalia. Now this is a very important, I would say, and you need to examine particularly the size of the testes and any structural abnormality with the penis and the pubic hair. So if there is an abnormality, then the investigation may be channeled in a different direction. So genitalia must be examined. Now let's talk about the investigations. I think in a first test of investigation, these are the tests you need to do. First of all, we would like to know the status of his diabetes. If not already done, you would like to do his HbA1c. Now, if his HbA1c is very high, we need to fix his diabetes. We need to test his testosterone level. Either you go for free testosterone or you go for total testosterone, but you also test then sex hormone binding globulin. This test is done in the morning because there is diurnal variation. Only if two readings are low, maybe interval of 2 weeks, 2 readings of testosterone are low, both done in the morning, that would confirm hypogonadism. Now, what is the importance of sex hormone binding globulin? This is a protein which is present in our body, which binds a significant amount of testosterone. And testosterone, which is bound to sex hormone binding globulin, is inactive. And with aging, this SHBG increases. So in elderly person, if you test total testosterone, it may still be within normal range, but actual functioning testosterone would be low. So either you go for free testosterone or you test this one also, then applying a formula, you calculate free testosterone index. So that is what would be relevant to erectile dysfunction. Then we also test prolactin. You know, prolactin is a hormone produced by the pituitary, and that has got inhibitory action on all aspects of sexual function. So some people may have elevated prolactin. If that is the case, then you need to investigate it further. Many times this elevated prolactin would be due to some drugs. There are many drugs, some antipsychotic drugs, antidepressant drugs, anti-Parkinson drugs. These drugs may cause increased level of prolactin. So if possible, you would like to reduce those drugs or change them if possible. If the patient is not taking any of those drugs, then you might need to investigate pituitary gland to rule out any tumor which is producing prolactin called prolactinoma. Another test which is very useful is penile ultrasound. Now, ultrasonologists will do this test. Uh, Ultrasound is usually done after injecting one of those substances which are used for the treatment of erectile dysfunction, like piperine or alprostadil. That is injected into the penis, into the corpus cavernosum, and that would reproduce erection process, and then the sonologist will check the blood flow and the drainage of blood and the pressure with Doppler technique. It's extremely useful test. I think it should be done, and it is a non-invasive test. Then finally, those patients where everything else seems to be okay, then you would like to see the arteries of this person, and arteriogram of the pelvic vessel should be done, and sometime one of the branches of the internal iliac artery which supplies the penis, they would be affected. So of course that patient would require altogether different treatment. So this is the detailed evaluation of a person presenting with erectile dysfunction. In the evaluation, we also like to determine if the problem is psychological or physical, and psychological causes of erectile dysfunction are generally sudden and severe. And of course, there will be history suggestive of some psychological trauma. And this psychological could be selective also. But this point has been mentioned earlier, and I would like to emphasize it again, that those who have physical causes, because this is like considered like a personal failure for a man, a person with the physical cause of erectile dysfunction would definitely have psychological overlay. And the one with physical may be gradual worsening. It's usually not sudden unless there is a sudden cause like trauma to the pelvis or spine. So generally speaking, in diabetes, the erectile dysfunction would be gradually worsening if it is organic in nature, and there may be a possible cause, diabetes or autonomic neuropathy or vascular disease. So that may be the cause. So I think that is how we determine the etiology. Now, in continuation of evaluation, this is the barcode of John Hopkins questionnaire for erectile dysfunction. This is fairly lengthy questionnaire, about 7 pages, but very useful. You can use this. This is free to download, and you can scan this barcode and you will have access to the questionnaire. You can translate that questionnaire into our own language, and that you can use for the purpose of evaluation. Now we have done with evaluation, history taking, physical examination, lab tests, and the differential diagnosis between psychological and physical. Now let's examine the role of diabetes in the causation, the pathogenesis of erectile dysfunction, and the correlation between the two. Uh, in diabetes, there are several physical abnormalities which can affect erectile dysfunction. We have already mentioned autonomic neuropathy. You know, the erectile process starts with the stimulation of parasympathetic nerves. So if autonomic nerves are affected, then parasympathetic nerves will not release nitric oxide, then the whole process will not start. Then there may be vascular disease. After nitric oxide is released, and there is prostaglandins are released, then there is vasodilatation of these arteries. And if these arteries or their feeding vessels are atherosclerotic, they may not provide enough blood, so that could explain erectile dysfunction in diabetes. But I believe most patients with erectile dysfunction in diabetes are not vascular, unless there is evidence of vascular disease elsewhere also. So most are, I think, due to autonomic neuropathy or psychological causes or medication. Then atrophy of the trabecular smooth muscles. These muscles, their trabecular smooth muscles may be atrophic, so they do not perform their function better. That may be responsible. Then obesity, hypertension, cardiovascular disease, smoking, all comorbidities of diabetes, they directly or indirectly adversely affect erectile function. So they also contribute to this process. Then medication, and then of course psychological factors. So this is how one gets erectile dysfunction in diabetes. Now, this is going to surprise you. Why? Because I was actually surprised when I studied this literature. The prevalence of erectile dysfunction as per duration of diabetes and age of the patient. According to one survey, patient with relatively new diagnosis of diabetes, within just 1 year of their diabetes, 23% of them, they had some degree of erectile dysfunction. Now, I think erectile function is also very subjective. But according to the questionnaire, John Hopkins questionnaire, 23% of the people, men, with just 1 year or less of duration of diabetes, they had some degree of erectile dysfunction. Those who had diabetes of 10 years duration, 50% of them, they had erectile dysfunction. And those who had diabetes of approximately 20 years and they were of 65 or plus, they had 90% chances of having erectile dysfunction. So it is a real big problem. 65 is not that old age. So I think one normally expect to be uh, sexually active at this age, but imagine if you are diabetic and your diabetes is poorly controlled and you have been diabetic for more than 20 years, the 90% chance that you will have erectile dysfunction. So that means the problem is very real and very prevalent. Okay, so I'm going to introduce a concept here, and diabetes is considered as coronary heart disease risk equivalent. There was a time, only recently, it was said that once you are diagnosed diabetic, it is as if you already have developed coronary artery disease. Then it was realized that it was slightly an overstatement, and it was, I think, rephrased that diabetes of 10 years duration is equivalent to having coronary artery disease. So since erectile dysfunction could also have a vascular origin, so I believe if you have diabetes of 10 years, it is as if you already have erectile dysfunction, and it is as if you already have coronary heart disease. So I think if this is vascular in origin, so indicating that if somebody with diabetes has got erectile dysfunction, that person should be put in that category. If you follow those guidelines of EASD and ADA, where patient with increased risk of atherosclerotic cardiovascular disease after metformin should be offered GLP-1 receptor agonist and SGLT2 inhibitors. I think patient with erectile dysfunction should also be put in that category. So we have done the evaluation. Now let's come to the treatment of erectile dysfunction. First of all, there are some natural ways to improve erectile function. A good diet, balanced diet, and exercise, including exercise of pelvic muscles, sleep, ample sleep, weight loss, psychotherapy, sex therapy, and stress reduction. Sorry for the slip. Stress reduction. There are various techniques. So all these should help to improve one's erectile function. Now this is the barcode of treatment plan of erectile dysfunction by Mayo Clinic. You can scan this and that will take to these guidelines. They have given step by step the treatment algorithm. But I'm going to reproduce it here. So before we start treating these patients, first of all, we would like to have better glycemic control. Perhaps using GLP-1 receptor agonists. They are expensive drugs, but whatever agents are available, we would like to achieve better glycemic control. I don't say that we should hold treatment of erectile dysfunction till you get better control. So I think we should work on both things simultaneously. And then remove possible drugs. There are a number of drugs which may be responsible or may be contributing to erectile dysfunction. You should examine them and if possible remove them. And one such drug is metformin. We all know metformin is extremely useful in the treatment of diabetes, but it has anti-androgen effects. Uh, in my understanding, there are no recommendation which would say that metformin should be withdrawn once somebody develops erectile dysfunction. But it is, I think, on individual grounds, if you think metformin is contributing, you could withdraw it and replace it with another drug. But mostly, in my practice, I continue metformin even if somebody has some kind of erectile dysfunction. Beta blockers, most conventional beta blockers, they have inhibitory effect on erectile function, but the newer ones like nebivolol is a vasodilator beta blocker and it actually causes vasodilatation and it may be helpful in erectile dysfunction, so that should be continued. Calcium channel blocking agents, they also have adverse effect, they may be withdrawn, and diuretics, for example, all diuretics, particularly spironolactone, that has anti-androgen effect, that should be changed with another diuretic if needed. Antidepressant drugs, antipsychotic drugs, anti-epileptic drugs, they may be necessary, but you can review the case and if they can be withdrawn, they should be done. They would improve the erectile dysfunction. Now the treatment options, we have a number of these options. I have highlighted just one because I'm going to focus on this one and then I will highlight other ones also and discuss them. The treatment of first choice is phosphodiesterase type 5 inhibitors, PDEIs. So these are the drugs of first choice irrespective of the cause of erectile dysfunction, whether that is psychological or physical. The treatment of first choice is PDE inhibitors. Uh, for example, we have this four of them: sildenafil, called Viagra; tadalafil is available with the name of Cialis; then vardenafil, Levitra; and avanafil, Stendra. The literature says that you could choose any of the four agents. There's nothing much which would prefer one over others. But there are two things which I would like to highlight. This avanafil Stendra, is the fastest acting. Its Tmax is only 30 minutes. That means after ingestion, it would have its maximum effect at 30 minutes. So that may be desirable. And all other, they also claim that the effect starts at 30 minutes, but the peak effect is achieved in approximately 2 hours. So if you're using these drugs to have the optimum response, you should take them 2 hours before the activity. And tadalafil has got the longest action. It works for 36 hours. So that means if you take one tablet, you could perform sexual activity 2 times, maybe after 24 hours, you could have another sexual activity. So using these factors, you could choose any one. But you know, in our country, none of these drugs are registered, but they are available. They are available fairly expensive. They're fairly expensive. And because they're not registered, they are sold in black market and they are available. And when you buy something from black market, you are never sure about its efficacy and whether this is a genuine or fake drug. Now, this is the mechanism I have already discussed. I will not repeat it, but how do these medicines act? This phosphodiesterase inhibitor, they actually this is an enzyme which deactivates nitric oxide. So once somebody takes this drugs, conversion of nitric oxide to cyclic GMP and further degradation will be halted. So there will be no degradation of these substances. They will stay in the system and they will keep the erection for several minutes. So this is the philosophy of phosphodiesterase 5 inhibitors. Now it is important to know that these will work only if there is arousal, there is natural erection. Okay, so this will only prolong erection, will strengthen erection. They will not cause erection unless there is arousal. So this is actually a good feature. Side effects of phosphodiesterase inhibitors. No drug is without side effects. One common side effect is headache because these are vasodilator drugs and they cause headache and which may be mild to moderate and may last for 24 hours. Then hypotension, especially if taken with nitrates. Somebody who is taking nitrates, he should not use phosphodiesterase inhibitors unless he stops nitrates. Nitrates are given for active ischemic heart disease, and I believe active ischemic heart disease in itself is perhaps contraindication for the use of these drugs. And those patients who have been prescribed nitrates, they can take some time off nitrate and then use PDE inhibitors to avoid hypertension. Then sudden death. During sexual activities, 1 out of 50,000 incidents of sudden death due to sexercise. You know, during sexual activities, the sexual activity has about 5 to 6 METs. That means your oxygen requirement is increased 5 to 6 times. That is significant burden on cardiovascular status. Now, if somebody has normal cardiovascular status, that 5 to 6 time increase is not a problem. But somebody who has heart disease, this could precipitate ischemia, and in very rare cases, it may cause sudden death. So I think these are contraindication. Otherwise, this drug is fairly safe. There are some natural ways to improve one's sexual function. These drugs are available. They are not registered, but they are available. They may be used. I don't know how do they work, but perhaps their function is similar to this sildenafil because they have vasodilator action. Uh, L-arginine is a precursor of nitric oxide. Euhumbine is available natural product. It increases libido. Ginkgo biloba is actually vasodilator. And Tribulus terrestris is also a drug which increases one's libido and causes a better erection. So these are drugs. They have not rigorously tested, but I found a paper which showed that they are effective. This is a paper published in Arab Journal of Urology, and alternate medicine and herbal medicine in the treatment of erectile dysfunction is systemic review. They concluded that compared to placebo, these drugs, they are helpful. I mean, they are effective as compared to placebo. Now, if somebody does not respond to phosphodiesterase type 5 inhibitors, or if these drugs are contraindicated and the alternate medicine is also not working, then you could use this treatment, intracavernosal or intraurethral administration of these drugs. Piperine is a vasodilator. Alprostadil is also a vasodilator. This is active form of prostaglandin E1, and it can be injected intracavernosally like this one, or it can be given urethrally. And then there is a drug with 3 drugs in it: piperine, vasodilator; alprostadil, vasodilator; and phentolamine, an alpha blocker, is again a vasodilator. All 3 drugs mixed in one injection may be given intracavernosally. Now, intracavernosal injection, there is 50 to 90% response. So when it comes to efficacy, they are very effective, about 90% effective. And most people, they would get sufficient erection to make the intercourse possible. But only with these drugs, people will get full rigidity. With phosphodiesterase inhibitors, you do not get full rigidity. But these cavernosal injections, they will give you full rigidity. So that is the plus point, but acceptance may be poor because of the fact that you have to inject into the penis. That is not easy to accept. Then the cost and the associated side effects and the expensive. And in one person, it may cause priapism. That may be very serious and embarrassing situation, sustained erection for which may last for hours, and with repeated use, there may be some fibrosis in the penis. So these are the side effects of these intracavernosal injection, but they are very effective. Then we have these vacuum devices. You can see this is a vacuum device which is motorized. Now, after arousal, you use as shown in the picture. This will suck blood into the penis and will cause erection. Now, those who have used this device, they say it is surely effective, but they have described that the erection is not normal to see and normal to feel. I mean, so this is a kind of mechanical erection. So, but this is effective. Then we have implants. There are two types of implants, and this is the one inflatable. This is the reservoir containing silicone, and this is the motor. If you activate this motor by pressing, the silicone from this bladder will be transferred into these things in the penis, and immediately erection will occur. So this, of course, would be a major undertaking. It requires major surgery, and this is the treatment of last resort. Those who are very keen to restore their erectile function and none other medicine has worked, they may be considered for this surgery. And some patient with vascular abnormality, atherosclerotic disease, they may be considered for stenting, like this one, and this is the stent, or grafting, like we do in coronary artery disease. So stenting and grafting may be considered for pelvic arteries in those patients who have this arterial disease. So this was the treatment of erectile dysfunction. Now we're going to take up associated abnormalities, some other sexual abnormalities. And one of them is associated androgen deficiency, diabetes and metabolic syndrome with androgen deficiency. Now this was a paper published in Current Opinion in Endocrinology and Diabetes and Obstetrics. Androgen deficiency, diabetes and the metabolic syndrome in men. If you cannot maybe read this fine print, I have just bolded it. 20 to 64% of the people with diabetes and metabolic syndrome may have androgen deficiency. Isn't this alarmingly high figure? 20 to 64% patient with diabetes, they may have androgen deficiency. What is exactly the mechanism? I don't know, but this figure is very alarming. So that means you definitely need to assess their androgen levels and give treatment if they turn out to have deficiency. Now this is the graph showing menopause, which we all are familiar, and this is the andropause, which is seen in men, and there is gradual decline in androgen. This is like age-related process. This starts really at the age of 35, and there is gradual decline in androgen. And in diabetes, you may say this is relatively premature. So that premature androgen deficiency is responsible for erectile dysfunction in some people. This is actually the joke. The clinical manifestation of androgen deficiency would be related to one's sexual activity from daily to weekly and then weekly. I'm sure you can guess what I mean. Now, when we do hormonal assays, this is the wide range. Typically, testosterone level ranges from less than 200 to over 1000. So there is a wide range. Whenever there is a wide range, it is usually difficult to interpret when they are borderline readings. So that's why the androgen level must be interpreted in the proper perspective. If somebody's level is in the upper half, then of course it is sufficient. But if it is in the lower third, it would be called insufficient. Now, this would be interpreted in light of patient's history. If patient has symptoms consistent with androgen deficiency, this may be treated. And if this patient does not have symptoms related to androgen deficiency, then this may be ignored. But those who have a low level, then of course they would need androgen replacement therapy. How do we do that? First of all, we try natural ways to boost testosterone, good fats, low carb diet, zinc, low stress, low reducing body weight, vitamin D supplementation, magnesium supplementation. They all help to boost one's testosterone, so they may be included in one's diet or in one's supplements. But many would require hormonal therapy. Though the overall plan is, first of all, we do clinical evaluation and we do laboratory evaluation. According to the laboratory evaluation, if testosterone was low, then we sit with the patient, have discussion, we discuss pros and cons, and if patient agrees, then we start on androgen. Now, treatment trial is given. We give it for 3 months and then reassess. On reassessment, we do again clinical evaluation and we do laboratory evaluation like we did in the beginning. And there are 3 possible outcomes. One possible outcome is that there was clinical improvement, patient's overall condition and patient's erectile function improved and testosterone level became normal. That obviously means that this therapy has worked and should be continued. And the second outcome is there is no clinical improvement and testosterone level is still low. I think the best response to this situation would be to increase testosterone dosage. And the third one is no clinical improvement, but testosterone has become normal. Then probably you should discontinue testosterone and rule out other possible causes of androgen deficiency, the symptoms, and the erectile dysfunction. So we have injection as a replacement therapy. We have testosterone available in the form of injection and oral tablets and gel. Injections are once fortnightly, although frequency varies in different persons. Some would require weekly, some would maybe sufficient once a month, but usual average frequency is once fortnightly. It may be painful, it may cause abscess if sterilized technique is not followed. It may have roller coaster effect because you inject and then you inject again after 2 weeks, so the effect may vary and the cost is very low. When it comes to tablets and gels, daily, once a day or twice a day, gel is to be applied on the body and tablets are to be ingested with meal twice a day. Convenient, but compliance is an issue. Patients often forget to take their pills. The effect should be uniform if patient takes it every day, and the liver side effects are possible because androgens are potential hepatotoxic, very mild effect. But current preparations, if taken with the meal, they are fat soluble drugs. They will be absorbed as is fat absorbed through the lymphatics. So they will actually they will bypass the liver and the testosterone will be taken to the systemic circulation bypassing liver. So the side effects related to liver are very, very rare. So, but once somebody is on this medication, occasional liver function should be done, at least the ALT level. And the cost is about 3 times of injection. Premature ejaculation, there could be non-pharmacological techniques and pharmacological techniques. Now, in non-pharmacological behavioral techniques, pelvic floor exercises, the pause, squeeze techniques, and condoms to minimize the sensitivity. And on pharmacological group, you could use topical anesthetics and SSRIs, selective serotonin reuptake inhibitors, depoxetine, available with the name of Everlong, or other SSRIs like paroxetine, the Seroxat. These drugs, they can prolong one's ejaculation time, so they may be used. Tricyclic antidepressant also are useful. Tramadol, which is a narcotic analgesic, that can also work. All these drugs, they have their own limitations. So in selected cases, you will discuss the pros and cons and then prescribe. Loss of libido usually due to some underlying psychological or neurological or endocrine cause that needs to be ruled out. But some natural herbs, some substances as given here, ambrine, yohimbine, honey goat weed, and marijuana, alcohol, ginseng, testosterone, they can improve one's libido, may be tried in some cases. So we have covered all agenda items, and now I'm pleased to present the summary. First of all, detailed evaluation is required. You need to acknowledge this problem as a real problem, and due time should be given to the patient. A separate meeting should be done with the patient or with the patient and the partner. Rule out all causes which are treatable, and then get better glycemic control, and then you start treating patient with erectile dysfunction. And the treatment of choice is low dose phosphodiesterase 5 inhibitors and testosterone if there is androgen deficiency also. If somebody has sufficient androgen level, then testosterone should not be used. Low dose phosphodiesterase inhibitor, any of the four available, should be tried. Initially low dose, and gradually it should be increased. Now, it is advised that patient should be instructed to use it 4, 5, 6 times before he concludes that this drug is not working. If it is not working, then you maybe try a higher dose. Now, if you take the example of sildenafil, you might start with 25 milligram and go up to 100 milligram. And if 100 milligram is not effective, then probably this medicine would not be effective at all. There's no point in continuing. If you use Cialis, then maybe you can start with 10 milligram, and if 10 milligram doesn't work, you could try 20 milligram. There's no point in trying combining two phosphodiesterase inhibitors. Now, if they're not effective, then you may try alternate medicines because they're not rigorously tested scientifically. But before going to the next step, because next step is expensive and not readily available, I think one may try alternate medicines, maybe in combination with phosphodiesterase inhibitors. So consider injection or device therapy if available, and if not acceptable, not effective, or not available, then I believe you have to use penile implants, and of course, and only in desperate people this would be considered. And I believe there would still be some cases who would have to live with erectile dysfunction. So I think we have tried our best, but those patients who uh, do not have any treatment available or any treatment effective, they should try to cope with this problem. And not to mention, but there are other ways of sexual gratification, so the patient can try those. Thank you. This has been Professor Aziz-ur-Rehman from Medurstand, and I'm sorry this was a relatively lengthy lecture, but I could not divide the topic into two. So this was an account of erectile dysfunction and other sexual abnormalities, particularly in reference with diabetes. And I really look forward to see you in my next video, which is going to be on another important topic. Till then, look after yourself, and I look forward to see you again in my channel. Thank you.